Welcome to Unit 6. Today we're going to discuss hypersensitivity reactions, autoimmune disorders and diseases, and hepatitis. So hypersensitivity is basically an overload of the immune system associated with allergies, transfusion reactions, glomerulonephritis, and many other things. The degree of severity can be mild to life-threatening. The source of antigenic exposure is not always known. These atopic illnesses were one of the first antibody-associated conditions known to have genetic tendencies. Atopy refers to immediate hypersensitivity mediated by IgE. Immediate hypersensitivity is mediated by antigen-antibody complexes, while delayed hypersensitivity is cell-mediated. Being sensitized to an antigen can actually be a good thing for the host. Here's a few terms. Immunity is protection against an environmental agent. Immunization is acquisition of protection by contact with antigenic material. Other times, being sensitized to an antigen can cause harm to the host. Here are a few terms. Hypersensitivity is a higher immune reactivity, an overload of the immune response. An allergy are all those annoying things like sneezing, watery eyes, itching, and hives. Anaphylaxis is a body-wide response, systemic effects of mediators released after antibodies react with antigens. And atopy is a predisposition to allergies against common agents in the environment, or immediate hypersensitivity mediated by IgE. Here I have a few more terms for you. Exogenous is material originating outside the host, such as dust or pollen. Endogenous are elements that are native to the host, such as autoimmune disorders when we recognize self or non-self. And heterologous or xenogenic is exogenous stimuli from non-human sources. It's an external antigenic substance like pet dander, peanuts, etc. There are four types of hypersensitivity reactions. Type 1 is called an immediate reaction. Substances that cause type 1 hypersensitivity reactions are generally inhaled, ingested, or injected. I think of things like dust mite feces, pet dander. Things that are ingested would be peanuts or shellfish, and then things that are injected would be something like a bee sting. Listed here are the four types of hypersensitivity reactions. The names refer to the mechanisms of reactions. Type 1 is immediate hypersensitivity reaction. Type 2 is cytotoxic hypersensitivity reaction. Type 3 is immune complex hypersensitivity reaction. And type 4 is delayed type hypersensitivity reaction. Types 1, 2, and 3 are humoral or antibody mediated, while type 4 is cell mediated, brought about by lymphocytes. There is some overlapping of the types that can occur. Type 1 immediate hypersensitivity involves IgE. The target cell for IgE would be the tissue basophils or mast cells. Complement is not involved. The granules of mast cells contain substances like histamine, slow-reacting substance of anaphylaxis, and bradykinin. Histamine causes smooth muscle contraction of the bronchus. SRSA causes increased mucus secretions and contracts smooth muscles. Bradykinin causes edema and smooth muscle contraction. Some examples of a type 1 immediate hypersensitivity would be hives, bee stings, and fever. Type 2 hypersensitivity reactions are cytotoxic. The IgG and IgM is involved in this type of hypersensitivity reaction. The target cells affected by cytotoxic reactions would be red cells, white cells, and platelets. Complement is involved in the reaction. Some examples of type 2 hypersensitivity reactions would be transfusion reactions, hemolytic immune responses, and hemolytic disease of the fetus and newborn. The third type of hypersensitivity reaction would be the immune complex type. This is an insoluble complex of antigen and antibody that causes excessive inflammation. IgG and IgM are involved. The host tissue cells that are involved are kidney tissue, lung tissue, etc. Complement is involved. The mechanisms of reaction are immune complexes, and some examples of type 3 hypersensitivity would be serum sickness, glomerulonephritis, or farmer's lung. Type 4 hypersensitivity reaction is the delayed type hypersensitivity reaction. There are no antibodies involved in this type. This is a cell-mediated type of hypersensitivity response. The targeted cells are T cytotoxic cells, T delayed type hypersensitivity cells, and macrophages. Lymphokines are the mechanism of reaction. They release soluble mediators, and these are secreted by T cells. Some examples of a type 4 hypersensitivity reaction would be poison ivy reactions, dermatitis, graft rejection, and allergy skin tests. In order to make a diagnosis of a type 1 hypersensitivity reaction, we need to get a history of the patient. That's going to be very valuable to us. We need to look at their skin test results, and we can also look at their serum IgE levels. The treatment or therapy for a type 1 hypersensitivity reaction is to control the environment. In other words, stay away from allergens like foods, pet dander, and metals like nickel. We can desensitize the patient by giving them allergy shots. We can give those allergy shots over a period of years, and they can help the body acclimate to certain antigens. Or we can use certain drugs to treat hypersensitivity responses, such as antihistamines. Some general examples of an immediate hypersensitivity reaction would be allergic asthma. This is a chronic disease characterized by bronchial spasms, wheezing, and chest tightness. Allergic rhinitis, also known as hay fever, where you have a runny nose, sneezing, and itching. Or allergic urticaria, also known as hives. This includes welts and intense itching. Let's talk about type 2 cytotoxic hypersensitivity reactions and how they relate to transfusion reactions. IgE binds with infused red cells which activate the complement system. This is influenced by the number of incompatible cells that were infused. There are actually 4 types of transfusion reactions. The first is called an immediate non-hemolytic reaction, and this is associated with leukocyte and platelet antibodies. Then we have an immediate hemolytic reaction, which is very serious. You will see this type of transfusion reaction with ABO incompatibilities. As little as 10 mils of the wrong blood type can cause intravascular hemolysis. And then we have delayed non-hemolytic types of transfusion reactions. An example of that would be graft versus host disease, where the transfused cells actually reject the host. And then finally we have the delayed type hemolytic reaction. This happens 7 to 10 days after transfusion. It includes low red cell survival because cells become coated with IgG antibody. Some symptoms associated with the transfusion reaction would include things like chills, fever, hypotension, and back pain. Let's talk a little bit about cytotoxic hypersensitivity reactions and how they're related to hemolytic disease of the fetus and newborn. Rh-negative mother who carries an Rh positive child produces antibodies to the Rh antigen. They have no D factor. These antibodies will pass to the second child in utero. The RBCs of the fetus will lyse and erythroblast production will increase to compensate for the loss of red cells. This results in excessive destruction of fetal cells by mom's antibodies. There are 2 types of skin tests for allergies. One is called RIST and one is called RAST. RIST is radioimmunosorbent assay test. This measures the total IgE levels in serum. And RAST is radioallergosorbent assay, which measures specific IgE in patients with a known history of allergies. So here let's take a look at the mechanism for the type 1 immediate hypersensitivity reaction. Here, IgE antibodies are fixed to mast cells and react with an antigen. This triggers the release of various chemical components leading to rapid tissue damage. In a type 2 cytotoxic hypersensitivity reaction, IgG or IgM react with an antigen on target cells like red cells. Complement is activated, causing cells to lyse. In a type 3 hypersensitivity reaction, IgG or IgM forms complexes with the antigen and complement. This generates neutrophil chemotactic factors, resulting in local tissue inflammation. The type 4 hypersensitivity reaction is a cell-mediated reaction where antigen binds to a specific T cell, causing the cell to release a variety of soluble mediators called lymphokines. This produces noticeable inflammation. Okay, let's switch it up a little bit and jump into the autoimmune diseases. So, autoimmune disease is a group of misunderstood diseases when the body cannot discriminate between self and non-self. It begins with an abnormal interaction of T and B cells with autoantigens, where antibodies and T cells display specificity for self-antigens. Every immunocompetent individual is at risk of contracting an autoimmune disorder given the appropriate circumstances. There is no single theory or mechanism that has been identified as the cause of autoimmune diseases. Some factors that may influence the incidence of autoimmune disease would be things like genetics, age, and exogenous factors, external things like chemicals, bacteria, or metals. Various organs and tissues can be affected by autoimmune disorders. Some organs and tissues that can be affected by autoimmune disorders would be the cardiac tissues, the stomach and intestines, the liver, the brain, and the central nervous system. That's just to name a few. Thyroid autoimmune diseases. There are 3 different types of thyroid autoimmune diseases, including thyroiditis, Graves' disease, and Hashimoto's disease. Thyroiditis is seen in females ages 30 to 50. Some symptoms of thyroiditis would be fatigue, weight gain, depression, or feeling fuzzy-headed. They have an enlarged thyroid that's firm or hard in the way that it feels. Antibodies attacking the thyroid cells are anti-thyroglobulin antibodies, anti-microsomal, that's in the thyroid epithelial cells, anti-colloid protein antigens, and anti-thyronine, which is T4. The treatment for thyroiditis is thyroid hormone replacement therapy. Graves' disease is also known as hyperthyroidism, where the thyroid is constantly stimulated. Some symptoms of Graves' disease is that the patient is overactive and nervous. They have enlarged thyroids and enlarged protruding eyeballs. Some antibodies associated with Graves' disease would be anti-thyroglobulin antibody and anti-microsomal antibody. Excessive thyroid hormones and these 2 antibodies are produced in Graves' disease. In Hashimoto's disease, the patient has a hypoactive thyroid gland. The gland is large and rubbery. Some symptoms of Hashimoto's disease would be fatigue. They're sluggish. They have pale, dry skin and a puffy face. They also have muscle aches and stiffness. It usually strikes middle-aged females. Antibodies that are produced against the thyroid gland in Hashimoto's disease are anti-thyroglobulin, anti-microsomal, and anti-CA2. Some central nervous system autoimmune diseases are multiple sclerosis and myasthenia gravis. In multiple sclerosis, patients have a loss of vision and a loss of muscle coordination. Their loss of vision and muscle coordination is known as facial palsy, a lack of muscle coordination of the face. They also have lesions of the central nervous system, destruction of the myelin sheath of the nerves, and antibodies are formed against the myelin basic protein. Lab tests revealed decreased T cells, increased B cells, and increased IgG levels. The antibody produced against the central nervous system is called the anti-myelin sheath protein. There's a new theory that multiple sclerosis may be triggered by Clostridium perfringens toxin. Myasthenia gravis is a gradual progressive weakness of the striated muscle. Ocular muscles are often affected. So are the pharyngeal and skeletal muscles. IgG is the class of antibody involved, and antibodies formed against proteins present in the muscles. Muscle constriction and strength are thus impaired. The antibody produced in myasthenia gravis is anti-protein in striated muscle. There are a number of gastrointestinal autoimmune diseases, including pernicious anemia, ulcerative colitis, gastric atrophy, and Crohn's disease. Pernicious anemia is an inflammation of the gastric mucosa. These patients have an inability to secrete HCl, intrinsic factor, and pepsin. Intrinsic factor is the substance found in gastric juice that makes absorption of B12 possible. Needless to say, people with pernicious anemia have an inability to absorb B12. The antibody is formed against intrinsic factor, so the antibody is anti-intrinsic factor antibody. Ulcerative colitis is inflammation of the mucosa of the colon. It's an autoimmune disorder that is characterized by diarrhea and fever and dehydration. The antibodies are formed against the epithelial cells of the intestine. It's the IgG class of antibody that's involved in ulcerative colitis. In 2016, it was theorized that Mycobacterium avium may lead to Crohn's disease. If this is true, then a vaccine might be able to eradicate this disease. Let's go ahead and take a look at the liver autoimmune diseases, and that would include biliary cirrhosis and chronic active hepatitis. Primary biliary cirrhosis is a chronic impairment of the bile excretion where bile ducts are being destroyed. The antibody produced in this type of autoimmune disease is anti-mitochondrial antibodies. There's an indirect or in vitro test where patients make an antibody to rat kidney. In chronic active hepatitis, the antibody made against the liver would be anti-smooth muscle antibody. An indirect in vitro test where patients make an antibody to rat smooth muscle tissue. This brings us to the autoimmune injuries of the skin, and this would include pemphigus and vitiligo. Pemphigus is a blistering skin disorder where autoantibodies attack the glue between the epidermal cells. Vitiligo is a common condition of the skin depigmentation. Pigment-producing cells are destroyed. The treatment for this disease is steroid and phototherapy treatment. There are about 40 to 50 million people that have this condition. In the connective tissue autoimmune diseases, autoantibodies can be specific for nuclear antigens. One common connective tissue autoimmune disease is systemic lupus erythematosus. Rheumatoid arthritis is another connective tissue disease. Antibodies associated with connective tissue diseases are anti-nuclear antibodies. In other words, antibodies are able to react with the nucleus of a certain cell. Any immunoglobulin can be involved. Systemic lupus erythematosus actually means red wolf. This is an inflammatory disease which binds capillaries and small blood vessels. It is a chronic disease which may have periods of remission. It is systemic and collagen is destroyed, which binds to capillaries and small blood vessels. Noted on the left is the butterfly rash that is commonly associated with systemic lupus erythematosus. This affects 10 to 40-year-old females, and it is a chronic disease characterized by fever, malaise, joint pain, ulcerations of the fingertips, nausea, and vomiting. Here, in lupus, damaged white cells release their nuclear material, which is engulfed by the lupus erythematosus cell, otherwise known as the LE cell. Sometimes this cell can be seen in the peripheral blood smear. Serum in systemic lupus erythematosus contains anti-nuclear factors. Patients end up succumbing to renal failure due to immune complexes deposited in the kidneys. Anti-nuclear antibodies. Anti-nuclear antibodies are directed against components of a cell's nucleus. Anti-nuclear antibodies are seen in lupus, rheumatoid arthritis, and scleroderma. Anti-nuclear antibodies can be detected by observing fluorescence of nuclei of donated human or animal epithelial cells. Human or animal epithelial cells or tissue cells are used for the anti-nuclear antibody fluorescing patterns. Crithidia, which is a protozoan, can also be used to detect double-stranded DNA. This organism contains intracellular organelle known as the kinetoplast, which is rich in double-stranded DNA and lacks other nuclear antigens. Let's take a look at some patterns on the next slide. So here we've done the fluorescent test where we're looking at anti-nuclear antibody patterns, and what you're seeing in these images is the nucleus of a donated cell fluorescing, and those patterns determines what type of condition they have. So on the top left, this is called a homogeneous pattern where that nucleus is completely stained with a fluorescent tag. Generally, this type of pattern is associated with lupus. In the top right, you can see what's known as a nucleolar pattern. In the bottom left, this is called a speckled pattern. And on the bottom right, this is called a rim pattern or a peripheral pattern. These fluorescing patterns correlate to specific diseases like lupus. The procedure for fluorescing anti-nuclear antibodies is pretty simple. We're going to take serum and cells and we're going to mix them. The cells are already on the slide. We're taking donor cells or crithidia and we're mixing them with patient serum. We incubate the slide for a half hour at 35 degrees. We wash off our excess serum with phosphate buffered saline. We add a fluorescent tagged antibody and we incubate some more. We wash, dry, and examine the slide using a fluorescent microscope, and we look at the fluorescing patterns of the nucleus of the cells. Let's talk about hepatitis. This is a disease of the liver that can be mild or transient. It can be severe, prolonged, and even fatal. Hepatitis can be caused by two types of agents. Non-infectious agents, those would be things like toxins and pharmaceutical agents, things like alcohol, herbal and regular medications like acetaminophen. Or hepatitis can be caused by infectious agents, including things like the hepatitis A virus, the hepatitis B virus, and the hepatitis C virus. Viruses that are known to only attack the liver and have little effect on other organs are the hepatitis A, B, and C viruses. The hepatitis A virus. Outbreaks have been linked to ingestion of raw seafood from waters contaminated with human waste. It is spread by the fecal-oral route. This is also known as infectious hepatitis. It is a single-stranded RNA enterovirus. There's a short incubation period of about 15 to 50 days, with the mean being about 30 days. It is associated with overpopulated situations or areas of overcrowding where people bathe, wash clothes, defecate, and do dishes all in the same water source. This has a 0.3% mortality rate. In the United States, about 125,000 to 200,000 infections occur every year, but this is on the decline. There's about 100 deaths per year of hepatitis A in the United States. This is an acute onset disease where the patient will have a fever, anorexia, right upper abdominal pain, nausea, and jaundice. In fact, 70 to 80% of the people that have hepatitis A will develop jaundice from intravascular hemolysis. Usually that can be seen in the sclera of the eye, under the tongue, and on their skin. There are a number of laboratory tests that can be done to help diagnose hepatitis A virus. One is an immune adherence test. This takes a known antigen and adds a fluorescent tag and looks for the antibody. Another is complement fixation. Another is radioimmunoassay, where we look for antibody by use of a radioactive isotope added to an antigen. And then finally there's EIA or ELISA for anti-HAV antibody. All these tests detect the antibody to the hepatitis A virus. The hepatitis B virus is a very serious viral infection. It's one of the most common pathogens with 300 million HBV carriers worldwide. About 5,000 people die in the U.S. every year due to liver disease associated with hepatitis B virus. It is a double-stranded circular DNA virus. It's also known as serum hepatitis. There is a longer incubation period for hepatitis B virus than there was for hepatitis A virus. It is associated with sharing needles, transfusion, sexual contact, blood and body fluid contact, and can go from mom to baby. Hepatitis B virus is 100 times more infectious than the HIV virus. Some symptoms of the hepatitis B virus would be fatigue, joint pain, right upper quadrant pain, nausea, and jaundice. The symptoms are more severe than those of hepatitis A virus. Recovery from hepatitis B is slow and it may develop into chronic hepatitis. The mortality rate for hepatitis B is about 0.5 to 1%. Laboratory tests for the diagnosis of hepatitis B virus would be ELISA or EIA, RIA, polymerase chain reaction, PCR, which amplifies a single piece of DNA and makes millions of copies through heating and cooling cycles, or hybridization or chemilumination detection, where we look for measurable light as the result of a chemical reaction. There is a vaccine that results in the low titer of anti-HBs, hepatitis B surface antibody. If you have hepatitis B core antibody, it means that you have had the disease. This never actually occurs from a vaccine. The hepatitis C virus, HCV, is a single-stranded RNA virus identified first in 1989. It's the most common form of post-transfusion hepatitis. 85% of people with HCV become chronically infected. The old name is hepatitis non-A, non-B, and it's a major source of hepatitis among dialysis patients. It's transmitted by needle sticks, transfusions, human bites, tattooing, and body piercing. It has a long incubation period. About 30,000 people get infected every year in the U.S. with hepatitis C virus. The World Health Organization estimates that 3% of the world population has been infected with HCV. Generally, having HCV is a mild disease with an absence of clinical symptoms. Hospitalization usually is not required. So people that have hepatitis C virus, they could be asymptomatic. They could have a little bit of jaundice. They will feel fatigue and have a little nausea. Laboratory testing for HCV would be EIA or ELISA, Western blot or RIA, or PCR amplification, or other nucleic acid amplification technology or molecular techniques. There is currently no vaccine for HCV, but one does exist for hepatitis A and hepatitis B. Hepatitis E is a single-stranded RNA virus first discovered in 1990. It is similar to hepatitis A with its abrupt onset. All cases of hepatitis E have been identified in people who have traveled outside of the United States. In fact, the hepatitis E virus is endemic to tropical and subtropical countries like India, China, and Africa. The infection is usually the result of poor sanitary living conditions, so in other words, it travels through the fecal-oral route. The mortality rate is about 2%. Hepatitis D is also known as delta agent hepatitis and was first discovered in 1977. It's most often associated with IV drug abuse. It's found only in people that are infected with HBV. The HBV vaccine will protect a person from HDV. There are about 20 million people that have hepatitis D virus. Having hepatitis D increases the severity of the HBV disease. The mortality rate is very, very high at about 20%, but that could be very high because usually people that have hepatitis D also have hepatitis B. And finally, the hepatitis G virus was first discovered in 1996. It is considered to be a blood-borne agent where 1 to 2% of blood donors have hepatitis G. It frequently occurs as a co-infection with hepatitis C virus. It does not appear to cause a clinically important liver disease, except for in populations of the immunosuppressed. The role of HGV seems to be unclear. There's no specific treatment, and the prognosis is good for those who have the illness. The illness doesn't last long and doesn't do long-term harm to the liver. So there you have it. In today's lecture, we've covered hypersensitivity reactions, autoimmune diseases and disorders, and hepatitis. So I hope you have a great day, and I look forward to speaking to you in Lecture 7.